It's my job to introduce Dr. GN Ramesh, and I'm very sure that most of the doctors, senior doctors and the others needs no introduction of Dr. GN Ramesh, because he's been here in Cochin as a lead gastroenterologist from way back from 1991 onwards. Now he's a lead consultant gastroenterologist in ASTER Medicity, a very well-known speaker, and has a lot of publications to his credits. He's a member of a lot of associations and been conducting a lot of conferences. Is well known. As Dr. Abraham was saying, he's very well known among us as our dear GN. So please, I welcome you, Dr. GN Ramesh. Now the topic today, it was the decision of the API this time that we will choose topics which has been relevant and been very useful for the practicing clinicians around, and especially for the young budding physicians. So today's topic is mainly about, we are all familiar that whenever we comes across, it's a practice now that most of the patients come with a set of investigation. Doctor, ഞാൻ എല്ലാ ടെസ്റ്റുകളും ചെയ്തിട്ടുണ്ട്, ഒന്ന് നോക്കിയിട്ട് പറയുമോ? That's a common word we hear. Not that we have asked for the test, but we find that most of them come with a set of tests. And out of that, for various reasons, we find that most of the patients will have deranged LFTs, either as your SGOT or SGPT elevated, or your bilirubin mean elevated, or an alkaline phosphatase isolated elevated. So a lot of permutations and combinations have been there that the patient come across to you. And we have a lot of queries, and a lot of physicians have their own standard of treating it. They all have their own set of guidelines or setup. But then we have a speaker who has been well known for all these things and been in a great practice in this type of difficulties. So he'll be able to tell us how to go about and set a guidelines for it. Thank you, and over to you, Dr. GN.
A warm good evening to you all, and it's an absolute pleasure to be back in API, an organization which actually gave me the roots. I remember those days when I was involved in the formation of Cochin Gut Club, and we used to have those monthly meetings, and I used to depend on API members for the quorum and the attendance. Of course, some of the faces have changed. There are some faces who are not here. But I owe to API a lot for whatever I am here, whatever I am today. And when I got this call from Abraham George, I was quite excited because I knew that I'm going to meet up with a lot of my old friends. So warm good evening to you all once again. The topic that I was given or asked to speak was elevated liver enzymes in an asymptomatic patient. What should I do? I've been given a time of 20 minutes. Well, hopefully I should be able to stick to that. Well, we all know that with the advent of wellness checks or executive health checks, a lot of people are being diagnosed with this problem called asymptomatic elevation of transaminases. Elevated liver enzymes and abnormal liver chemistry are common scenarios that every physician faces on a day-to-day basis. Evaluation can be challenging for the simple reason that you don't know what is significant, what is not significant. You don't know that whether it is a normal physiological phenomenon or is it a window to a potentially serious problem. The proportion of asymptomatic persons with abnormal liver chemistry ranges from 1 to 9%. I'll start off with a story, and probably the most important message for the audience here would come out of this first story. A 16-year-old boy admitted with fatigue, body aches of 2 days duration. Examination was unremarkable. The CBC was normal, mild hyperbilirubinemia. The transaminases definitely elevated. So the next best thing to do would be do the viral markers. B and C were negative. Because B and C are negative, treated symptomatically, the patient settled. 2 months later, he comes with similar symptoms. This time, beyond B and C, we do the hepatitis A, E, and also autoimmune, because this is the second attack. Young boy, so we think of Wilson's, ceruloplasmin, no KF ring. Also, we go beyond ANA and do the other autoimmune parameters also. And while we are waiting for these results, the patient improves. The recurrence of symptoms, elevated enzymes, again happened. And since all the other tests were negative, we did a liver biopsy. And as luck would have it, the liver biopsy also was normal. That is when he was then shifted from one of the peripheral centers to our center. We found that is a well-built, nourished child. The LFTs at that time were normal, and we were scratching our heads, what could it be? So he got this usual diagnosis of idiopathic hepatitis, query, viral, recurrent hepatitis, all those things. You know, it can confuse anybody. Well, we went to the detailed history, and we found that one of the residents, actually, it was the IMT residents, found that each attack was preceded by an undue exertion. And this is a history, probably he held it back till he came to our center. But when he came and when he was asked, a detailed questioning was done, he said that each attack is preceded by an undue exertion. The patient is getting cramps and sore all over. So the question was, does this patient have something else other than a liver problem? And we started thinking of various other conditions, and one of the conditions that was put up as a differential diagnosis was exertional rhabdomyolysis. Something that did evoke a little bit of sneer from some of the colleagues. He came again with same symptoms, and this time it was following an NCC parade. The evaluation showed, this time we had our minds ready because already it had been discussed, and one of the differential diagnoses was a rhabdomyolysis, and the evaluation showed a high myoglobin, urine myoglobinuria, lactate and pyruvate were normal. He straight away was advised a muscle biopsy, and the muscle biopsy was suggestive of a Duchenne muscular dystrophy. The message, of course, I want to start off with is all AST, ALT elevations are not due to liver disease. So just because a person comes with an elevated AST and ALT does not mean that he or she has a liver disease. We must be open to the idea of that a particular patient may be having a non-hepatic cause for elevated transaminases. Well, if you look at the so-called liver function tests, there are numerous non-hepatic sources also. For example, for bilirubin, you can have the red blood cells, and we know that hemolysis results in hyperbilirubinemia. AST, skeletal muscle, cardiac muscle, we know a person who has got an acute cardiac injury, the AST goes up. LDH, again heart and red blood cells. Alkaline phosphatase, we've been taught, not only the liver, there are many other sources of elevated alkaline phosphatase. So basically the so-called LFT is not really specific for LFT. Now what does the liver do? Liver has got numerous functions. It's called the factory of the body, the industry of the body, and the functions are plenty. But today, I will stick out my neck and say that the term LFT is actually a misnomer. And there is a move to change this term LFT to LCT, liver chemistry test. Why? Because the standard tests that come in the LFTs do not reflect the functions of the liver. AST, ALT, alkaline phosphatase, globulin, these do not reflect functions of the liver. Some of them reflect injury, some of them reflect inflammation. So if you look at the function test proper, it is three. One is a serum albumin, which is linked to the synthetic capacity of the liver. Second is the INR, again linked to the synthetic capacity of the liver. And bilirubin, which actually is linked to the organic ion transport mechanism of the liver, which again is indirectly linked to the liver functions. All the others are actually reflections or reflectors or indicators of liver injury, not liver function. So liver tests or liver chemistry tests could be divided into many: markers of hepatocellular damage, markers of cholestasis, markers of synthetic function, which I mentioned about, and markers of anion transport and detoxification, that is the bilirubin. So if you look at where exactly within the liver cells these so-called chemicals or enzymes are produced, you will find that the AST is basically a mitochondrial enzyme. ALT is a cytosolic enzyme. Alkaline phosphatase and gamma GT are linked to the canalicular membrane. So wherever there's a damage to the canalicular membrane, the gamma GT and the alkaline phosphatase are expected to rise. So how do we then approach an altered liver function that has been accidentally detected? We have to find out whether the patient is asymptomatic or symptomatic. We need to find out whether this has been recently detected or has been there for some time. And we need to look at the pattern. So if you look at the classification of the various liver tests, which we bundle them together as a liver function test, bilirubin is an indicator of organic ion transport. Aminotransferases and alkaline phosphatases are actually linked to hepatocyte injury. Albumin and prothrombin time are synthetic indicators of liver. And besides, of course, the ones that in smaller print, but I don't want you to confuse your own mind by trying to sort of gobble down all those. And there are some that are markers of inflammation and fibrosis. So if you have an abnormal liver chemistry, there are three questions you must ask. The first question is, does the patient indeed have an abnormal transaminase value? Just one report is not enough. You need to repeat the test in another lab preferably and confirm that this patient indeed has an abnormal transaminase or an abnormal liver chemistry test. The second question is, how much is elevation? If the elevation is less than 5 times upper limit of normal, it is mild. If it is 5 to 10 times upper limit of normal, it is moderate. And if it is more than 10 times upper limit of normal, it is severe. This works for all the liver chemistry tests. Then the third question is, what is a pattern? Now, patterns are predominantly reflecting hepatocellular injury, where you will have an increase in AST and ALT with or without an increase in bilirubin. The second pattern is a cholestatic pattern, where you have an increase in alkaline phosphatase with or without an increase in bilirubin. Then you have a mixed pattern, where you have both the transaminases are elevated, the alkaline phosphatase is elevated with or without elevated bilirubin. And the fourth pattern is just an isolated hyperbilirubinemia, which I'm sure each one of you would see on a day-to-day basis. Just an increase in bilirubin, everything else is normal. So now I go on to some of these case presentations and then pick up a few points and drive home some messages which I need you to take home. Now look at this case of a 34-year-old gentleman with fever, nausea, vomiting and abdominal pain of 1 week duration. On examination, patient is icteric. Investigations reveal all this. I think the diagnosis is staring at your face. If you have some residents here, you could risk guessing what this patient is having. Are there any residents? Any residents? All frontline are residents. You're all in the firing line. You can tell me what this patient, what is your analysis? Pardon? Viral hepatitis. Senior person is saying viral hepatitis. Do you agree? So what is the pattern? I'm talking about the pattern. Hepatocellular pattern. So you have a hepatocellular pattern, which I said first, increased transaminases with hyperbilirubinemia. Isn't it? And you find that the albumin is normal, which means that the synthetic capacity is normal. INR is normal, which means that the synthetic capacity is normal. So this is a classical description of an acute viral hepatitis. Ultrasound shows a diffuse hypoacute liver and edematous gallbladder. You should always keep in mind that the normal value of SGOT and SGPT, just for all of us, the cholesterol, the triglyceride, all those have come down from 250, 200, 175. The SGOT, SGPT values have also come down. For men it is 30, for women it is 19. 30 and 20, it's easy to remember. So anything more than 30 in men and anything more than 20 in women is abnormal, mind you. So by that yardstick, 5 times upper limit of normal, which is mild elevation of transaminases, would be for men 150 and for women 100. Anything more than that is not mild. It is moderate or severe. Understood? Okay. So this is something that you need to keep in mind, that the cutoff values have changed. Go on to case number 2. 56-year-old gentleman, known case of diabetes and hypercholesterolemia. So obviously we are looking at a situation where you have maybe having a metabolic syndrome, whatever it is. A routine health checkup, standard presentation, shows that the bilirubin is normal. AST 86, which is AST and ALT 86 and 123, which is mild. Serum alkaline phosphatase normal. Total protein is 6.8. Albumin is exactly half of that. INR is normal. Your interpretation. You can tell me. If I had a chocolate, I would give it to you. Yes, NAFLD, yes, spot on, because this is a typical okay. Typical presentation of NAFLD. But how do we analyze this? Is it only NAFLD or something more? What is this patient going in for? That is what I want you to, actually you should look at each of these values. This patient has got a mild elevation in transaminases. The clinical background is that of a metabolic syndrome. So obviously this patient probably has a non-alcoholic steatohepatitis. But more than that, this patient also has an albumin equal to globulin. And when does albumin get equal to globulin? When this patient is progressing on to? You can speak loud. Cirrhosis, very good. So here, this is a classic presentation of a person probably starting off as non-alcoholic fatty liver disease, but is going into cirrhosis. He is a high-risk patient. This patient needs intervention. Okay? So basically, if you look at mild elevation of transaminases, there are many causes. What I've shown in the left is a simplified format. Alcohol, medications, chronic viral hepatitis, and like Dr. Ramakrishnan mentioned, non-alcoholic steatohepatitis, autoimmune diseases, Wilson's, and of course, some of the hemochromatosis also. So these are the broad categories of conditions which result in a mild elevation. Mild elevation of transaminases, fatty liver, alcoholic or non-alcoholic, is the major cause. But very mild elevation, where the levels are less than 60, actually, for all of you, I would just let you know that it is acceptable to observe patients. Don't run after them. It's acceptable to observe them, people with less than 2 upper limit of normal, and no chronic liver condition or non-invasive tests. Liver biopsy in this group of patients has not been found to change the diagnosis or treatment. So the message is, if it is less than 60 and the patient does not have any feature of chronic liver disease, just leave them alone, follow them up closely, advise them, counsel them. So these are the safe patterns. In the safe pattern, you'll find that the transaminases are always less than 150. They may fluctuate between a value of 30 and 150, but never more than 150. But this is what is an unsafe pattern. You could go, it can go on to 150, come down, go on to more than 150. This is an unsafe pattern. So if your patient is exhibiting an unsafe pattern over an observation period of 4 to 6 weeks, I think that is an indication when this patient needs much further evaluation, including maybe a liver biopsy. And the important questions that we're going to ask the patient is, what is, of course, other than the age, signs or symptoms of chronic liver disease, the risk factors of viral hepatitis, comorbidities, diabetes, obesity, hyperlipidemia, neurological problems or emphysema, alcohol history, family history. We are seeing a lot of patients, more and more patients of inflammatory bowel disease presenting with abnormal liver functions, celiac disease presenting with abnormal liver functions. So you need to look at that angle also, and other autoimmune diseases. The second important thing that you must look at in the aminotransferases is the AST-ALT ratio. Normally, the ALT is more than AST. AST, I did mention, is an indicator of mitochondrial injury. ALT is an indicator of cytosolic injury. Mitochondrial injury is definitely more harmful. Cytosolic injury, not all that harmful. So, you'll find that in patients with alcoholic liver disease, you'll find that the AST is higher than ALT. In a non-alcoholic fatty liver disease who has not gone into cirrhosis, AST is less than ALT. Cirrhosis, AST becomes more than ALT. So you must look at the AST-ALT ratio, and that also gives you a wealth of information as to what this particular patient would probably be having. And this is basically what it shows. You have that black line, which is AST-ALT ratio of 1. The moment it goes above that, it means that the AST is more than ALT. Below that, the ALT is more than AST. In the so-called benign liver conditions, or less harmful liver conditions, you find that they all tend to be below that line. But when the patient becomes cirrhotic, and as the stages of cirrhosis keeps going up, you will find that the ratio also reverses and becomes more and more. And this is why you find, you look at this color coding, you find that the ones in the blue are the ones where the AST becomes more than ALT, and that is basically 3 conditions: alcoholic hepatitis, cirrhosis of any cause, acute injury in an alcoholic, and probably you could also add some of the drug-induced liver disease. So therefore, how do I then approach a mild aminotransferase abnormality? I would like to spend some time here. A patient with a mild alteration in the aminotransferase levels, you consider the clinical context of the enzyme abnormality. So you have to ask all those questions: age, this thing, that thing, diabetes, hypercholesteremia, comorbidities, everything. But at the same time, you also keep your eyes open for the for the possibility that you need also to look at extrahepatic causes. Does this patient have anything other than the liver problem? If there is a history of alcohol or medication use or both, the first step is to stop them. Stop alcohol, stop the medications, observe over a period of 4 to 6 weeks, and see whether the alteration persists. If the alteration comes back or does not persist, comes back to normal, you have a diagnosis. It is something that has been induced by alcohol or the drug. But if it persists, then you are barking up the wrong tree. You need to rejuggle your possibilities and then come back to the main track, and then that is where you start looking at 3 questions. First, the risk factors for hepatitis viruses. Second, what is the transferrin saturation and serum ferritin? Third, in a middle-aged woman with or without a concomitant autoimmune disease, maybe that woman may just have a patch of vitiligo somewhere, may have had a thyroid problem sometime. These are all indicators that this patient could be having an autoimmune problem. So therefore, once you have ruled out alcohol and drugs, the number 2 would be to look at hepatitis viruses. Number 3 would be to look at the iron overload situations. Number 4 would be to look at autoimmune. Once you have considered all these, by and large about 80 to 90% of your workup in a particular case is over. 10% you may still be, be facing some sort of an unusual cause. Now, hepatitis viruses is very easy. For hemochromatosis, you need to look at transferrin saturation and serum ferritin, and also test for the HFE mutation. And for the autoimmune, you will need to look at ANA, ASMA, anti-LKM, and gamma globulins. Now, if everything is negative, then you go on to the last 10% or 15%, where you come to Wilson's, alpha-1 antitrypsin, and once you've ruled all that out, you are left with a chunk of conditions which we usually label as cryptogenic, but most of them would be non-alcoholic fatty liver disease. Now, you could actually turn this algorithm the other way, because as I said, the largest proportion of patients who come to us are those with metabolic syndrome, those with lot of comorbidities, a lot of them would be having non-alcoholic fatty liver disease. So nowadays we try to diagnose non-alcoholic fatty liver disease in a positive manner rather than it being a diagnosis of exclusion. People ask me when to biopsy. Do we really need to rush into biopsy? To be very honest, the role of a biopsy has really come down. Why? Because we all agree that it is an invasive test. No one likes to be biopsied, and I also don't like my patients to be biopsied because I know it is a potentially harmful investigation. But then, if you have a persistent elevation for which you are not finding out any answer, if during the course of discussion multiple diagnoses have been suspected, or to assess the grade of inflammation or to provide reassurance to the patient and the physician, we do biopsies. But let me tell you, liver biopsy rarely changes management. It is more for satisfying some of the requests and some of the ideas that come to our mind. It helps in documentation. Well, these are the various conditions. I will not go through them in detail because non-alcoholic fatty liver disease, suspected alcoholic liver disease, drug-induced, and any drug can be used, can cause this problem. Hemochromatosis, mind you, transferrin saturation value is the most important thing, not serum ferritin alone, because serum ferritin is an acute phase reactant. So if you really look at a specific test, it is a transferrin saturation. And a positive screen, of course, is basically a liver biopsy and doing this test. Wilson's, ceruloplasmin, slit lamp, and 24-hour urine copper of more than 100. And autoimmune, a lot of antibodies. But liver biopsy is crucial. Plasma cells in a liver biopsy means that this patient is having an immune-mediated liver injury. That is why liver biopsy is very crucial. So, sorry. Now, what do you do in a patient who has got moderate to severe elevated transaminases more than 10 times, the conditions are a few. Normally, we have viral hepatitis. Alcoholic hepatitis will never give rise to more than 10 times because of the fact that there is a deficiency of an enzyme called pyridoxal phosphate. So you have a ceiling. The transaminases never usually go beyond 500. Viral hepatitis, drug-induced toxic hepatitis, autoimmune hepatitis, acute Wilson's, ischemic hepatitis, all these conditions can present with severe ALT elevation. So we must obviously look at risk factors. Did this patient have a cardiac arrest? Did this patient go into a shock? Because the commonest cause of a sudden rise in transaminases to 10,000, 15,000 is actually a patient who's gone through a period of shock and the liver has had an ischemic injury. That actually causes marked elevation in transaminases. The third case, this will be slightly more easy. A 68-year-old gentleman with history of high-colored urine, fever, pruritus, deep icterus, bilirubin of 16, ALT 68, ALT 80, AST 67, and alkaline phosphatase of 600. What do you think this patient is having? Obstructive jaundice. Why do you say obstructive jaundice? Why don't you say cholestatic jaundice? See, by obstruction, you are now limiting yourself only to one particular group of problems. You must realize that the data that has been provided to you could be either an intrahepatic cholestasis or an extrahepatic cholestasis. When you say obstruction, it is extrahepatic. So you should say cholestatic. So obviously there is a cholestatic jaundice. Patient has got pruritus. So obviously there is a. So now the cholestatic pattern of LFT improvement, more often than not, they are symptomatic. Alkaline phosphatase of more than 3 times upper limit of normal. The transaminases may be normal or they may show a mild increase. The bilirubin shows mild to severe increase. When we are confused, we look at gamma GT. If you have gamma GT elevated along with alkaline phosphatase, it means that the source of the alkaline phosphatase elevation is the liver, nothing else. If you have an alkaline phosphatase elevated with normal gamma GT, then the source is not the liver. You have to look at other causes. You understood? The muscles, the red blood cells, a lot of other things. So if you have a gamma GT which is confirmatory, then you do an ultrasound. And this is a diagrammatic representation of what I was saying, that on the left you find the blood, and then the unconjugated bilirubin goes through the endoplasmic reticulum and then gets conjugated and then goes to the canalicus, and wherever there's an obstruction, this patient would be having a conjugated hyperbilirubinemia. There are 2 types, one that happens at the level of the canalicus and beyond, which is extrahepatic, one that happens in the cells, which is intrahepatic. Mind you, there are 2 age groups where alkaline phosphatase elevations can be normal. Children, even today I get referrals from pediatricians where children are having an increased alkaline phosphatase. It is very simple. Children with growing bones will have an increased alkaline phosphatase. The best thing to do is go do a gamma GT, tell them, reassure them, nothing's going to happen. And another is elderly age, where there is osteoporosis. There again you can have an elevated alkaline phosphatase. In both these conditions, gamma GT will be normal. So there has been alkaline phosphatase can be elevated in pregnancy, the 3rd trimester and the postpartum. Here again the gamma GT is normal. And after the delivery, it takes about 2 months for the alkaline phosphatase to come back to normal. So approach to altered liver functions, in this particular thing, the next best step would be to do an ultrasound, imaging, to see if there is any block. If there is an elevated transaminases, we could think of intrahepatic cholestasis. If the transaminases are normal, we would think of a post-hepatic or extrahepatic cholestasis. And these are the many conditions that can give rise to a cholestatic pattern. The fourth case is a 30-year-old male with fever, myalgia, high-colored urine. You have hyperbilirubinemia, AST, ALT 126, 127, alkaline phosphorus is also elevated, 6.5 with an albumin of 3.8, prothrombin time is normal. What sort of pattern is this? This has got, it's called what we call as a mixed pattern. Now, mixed pattern is probably one of the commonest presentations, because you will get that in any form of liver injury, where there is a damage to the endoplasmic reticulum, damage to the mitochondria, damage to the canalicular membrane. So wherever you have this, you will have all these levels going up. So that actually confuses the pictures, and one of the common things which we see are leptospirosis drugs. And finally, a 16-year-old boy presented to the OPD with saying that he's got yellow eyes, and you do a liver chemistry test. I will not say a liver function test, liver chemistry test, and I see that many of you are smiling. What do you think would be your analysis of this particular situation? I heard it from the back, Gilbert's, but how do you analyze? Now, what sort of abnormality is this? I want you to come out, analyze what, then you can come to Gilbert's. It is an unconjugated hyperbilirubinemia, isn't it? It's normally all the 4 cases that I showed you were conjugated hyperbilirubinemia. But here you have the conjugated fraction is normal. It's an unconjugated hyperbilirubinemia with normal transaminases, with normal alkaline phosphatase, with a normal AG ratio. So that means the liver is normal, isn't it? So now if you look at the schematic representation which I had shown you behind some time back, you have again the left, the blood stream, the blood enters, the unconjugated bilirubin enters in the endoplasmic reticulum, it gets conjugated, and then it goes to the canaliculus, and that is how it goes into the bile. And the problem can happen in any one of these 4 steps. One indicates increased destruction, hemolysis, where you can have unconjugated hyperbilirubinemia. Second, it can happen at the uptake level, again unconjugated hyperbilirubinemia. Third, at the endoplasmic reticulum level, again the conjugation does not happen, unconjugated hyperbilirubinemia. The fourth one, which happens later, is a type of congenital hyperbilirubinemia where you could have conjugated hyperbilirubinemia, but without any other damage. These are all very specific enzyme defects which result in conditions which do not have a bearing on future life. And so that's why these patients have to be reassured. So you'll have a high total bilirubin, a normal conjugated high fraction, unconjugated hyperbilirubinemia. What we usually do is we ask for a retic count, LDH, peripheral smear, or if the levels are high, we also probably could ask for an osmotic fragility and Coombs test. But the simplest test that we can do is a urine test. When they come, I just ask them to go and get that urine, bile salts, bile pigments, and tell them that if both are negative, you don't have to come back to me. If either is positive, you come back, we'll sort out the problem for you. It's the simplest test. I still see patients coming with huge stacks of reports, serum bilirubin 1.9, 1.5, 1.8, 0.1 here and there, and then they are scared. Obviously, a lot of people also scare them, and they go to Ayurvedic practitioners, homeo, and they say, this is the end, you have to do something and all. So this is a simple test which is very reassuring, because invariably in all this group of patients, this test will be negative. And with both tests negative, you just, and tell them that next time you have a suspicion, first get the urine test done. If both are negative, don't worry. If anything is positive, either is positive, you come, then we will sort it out. So this is basically the prototype is Gilbert syndrome. I don't want to go into the details. So therefore, I end with the last question. Whenever there is an abnormal liver function, the question that is asked is it cirrhosis or not? Because people are scared of cirrhosis. Now, to look at whether the patient has cirrhosis or not, you have to go to history, physical examination, the blood test. I think for physicians, it's important to understand that there are some indirect indicators. If you have signs of CLD, palmar erythema, spiders, all those things are there, muscle wasting, all those we have been taught are signs and symptoms of reversal of sleep rhythm. But also some indirect markers like falling platelets, low albumin, prolonged prothrombin time, and conjugated hyperbilirubinemia. These are all indirect indicators of cirrhosis, and our strongest investigative modality for diagnosis is ultrasound. And today we have the luxury of having the elastography or the fibroscan also along with us, which tells us straight away what the liver stiffness is like. And then we follow it up with other investigations. So to conclude, liver function tests are very, very, very useful. In fact, you will on a day-to-day basis, and if you are involved in a wellness clinic, even more, but all physicians would be faced with such a problem where either when they are managing cardiac patients, pulmonary patients, any other system patients, they may be having an elevated transaminases as a part of that whole medical problem. Laboratory has a crucial role to play, but I think more than laboratory, it is common sense, common clinical sense that has got a very crucial role to play. Isolated elevation of bilirubin is not at all important. Out of 100 isolated cases, you'll only find about 10 of them which probably would end up with a more serious diagnosis. Elevation of OT, PT, alkaline phosphatase is more important. Prothrombin time and serum albumin suggest a complicated disease. Many patients with normal liver transaminases have significant liver disease. So never think that if a person has a normal transaminase, he does not have a significant liver disease. The whole picture has to be taken together. That's why I said, if you have a transaminases, first question, does this patient have any features of chronic liver disease? If in a patient with a chronic liver disease, the transaminases are elevated, not elevated, still we need to pay attention to the more intricate factors. An unexplained elevation in alkaline phosphatase may represent an infiltrative disorder of the liver or could be a physiological variation. A prolonged INR in patients with cirrhosis may not necessarily be representative of a bleeding risk. An elevated serum creatinine in the setting of cirrhosis is associated with a poor prognosis. And the tail piece, of course, is when to consult a gastroenterologist, when to send your patients with abnormal liver chemistry to the gastroenterologist, unexplained or persistent elevation of enzymes, or more than 2 times upper limit of normal elevation for ALT or AST, or more than 1.5 upper limit of normal for alkaline phosphatase. These are the patients who deserve imaging and further evaluation. You can do it, someone else can do it, but it has to be done, and then based on the analysis, you take decisions about further management. So in this short time, I just thought I will, through 5 case scenarios, I will drive home a few messages which are linked to abnormal liver chemistry, which I think all of us should be wary about, should keep in mind. This is by no means a complete description of the abnormal liver functions. I know that I have missed out on some. I've purposely kept them aside because I did not want to complicate matters just beyond the transaminases, alkaline phosphatase, INR, albumin. That's a simple thing to understand, and once you've understood that, you've understood the complete thing about liver. Thank you very much for your patient hearing. I'm open to questions.
Thank you very much, Dr. GN. I know the subjects, he would be able to talk to us almost 2-3 hours, and that is where we will get all our queries and doubts cleared. But we can have a few questions, very specific, because we have another case presentation to be done. Anyone from the forum?
Statins, we all know when a person starts taking statins, there is an elevation of transaminases. But it has been now proven that this elevation has absolutely no clinical impact in the long run. As a result of which, now statins have been cleared of the earlier label of being hepatotoxic. It is just a biochemical effect, and there are no long-term consequences. So you'll find the transaminases going up a little bit. When should you stop statins in the face of abnormal liver chemistry? If you have a progressive increase in transaminases over a period of 4 to 6 weeks, or if you have a progressive hyperbilirubinemia. These are the two indicators when you should stop statins. There is no difference between the individual statins as far as this particular capacity is concerned. All statins are the same. And long-term reports of chronic liver disease because of statins are by and large very anecdotal and not proven.
Sir, are there any drugs which can be used to prevent fibrosis if you catch it early in the fibroscan?
Yes, there are drugs that have been that are available in the market. Obeticholic acid is one of them. Antifibrotic agents. Probably one of the first antifibrotic agents that came was D-penicillamine, but we never continued to use that. Obeticholic acid came up with huge promise, in fact, to the extent that FDA fast-tracked it because they thought it was a drug with a huge promise. But I believe, and in my opinion, that has also fallen by the wayside. So strictly speaking, there is no definite medicine which actually decreases the fibrosis. What we can do is control the risk factors. Fibrosis happens because of risk factors. The risk factors are uncontrolled diabetes, body weight, hypertriglyceridemia. These are all the risk, and of course alcohol. These are all the risk factors. Even sugars is also considered to be a risk factor. So risk factors we control. Medicines are probably more of a placebo, and lifestyle management may decrease the fibrosis. There is an interesting modality, and that is coffee. Coffee has been found to be hepatoprotective. Yeah, I see her nodding. I think you've heard of that. You have heard of that. But then, for coffee to be hepatoprotective, how many of you drink Starbucks? Have you been able to drink Starbucks without sugar, without milk? Without sugar, without milk. Now, for coffee to be hepatoprotective, it has to be very strong, taken morning, empty stomach, without sugar, without milk. But then there are reports that strong coffee is protective to the liver. And that is something, that is probably the only thing that we have at present to sort of decrease the chances or risk of progression of liver disease. Pardon? Glitazones, not very. Glitazones were the first ones to have been used. They've been abandoned because of the fact that there's a lot of fluid retention. And second is, they do bring about decrease in fatty liver, but they do not have any impact on fibrosis. Fatty liver will decrease, maybe lobular inflammation will decrease, but fibrosis has not been found to decrease. What decreases fibrosis is weight reduction and regular exercise. Just two things, no medicines. Weight reduction and regular exercise. Regular exercise, even if you don't reduce weight, actually can decrease the fibrosis. In fact, following bariatric surgery, there were studies that were done, liver biopsy at the time of bariatric surgery and liver biopsy after 2 years or so, paired liver biopsies. And they found that post-bariatric surgery with weight loss, actually the fibrosis also improved significantly. So it's all linked to lifestyle and body weight, that's all. Vitamin E is very, very popular. I use it very often. The first study for non-alcoholic fatty liver disease by Arun Sanyal used vitamin E as one of the arms, and they found that fatty liver decreases, also inflammation decreases. So vitamin E we still use, and especially in patients who are diabetics and have got fatty liver. Vitamin E we use. How long? We can use it as long as possible, but there are some side effects associated with a very prolonged vitamin E intake, including prostatic problems. So that is why we need to be a bit wary of that. But in the doses that we use, I think it is quite safe. 400 BD. Transaminitis, hypertransaminemia, all those are the same. Oh yes, it is approved. It all depends on which part of the world you go to. The British, they love to use the terminology transaminitis. MR. MRI is not a test which assesses liver function, so that's why it never featured in any of my slides. MRI is a way to visualize the liver, image the liver, and also MR elastography is probably the most accurate way, non-invasive way of assessing fat in the liver as well as fibrosis in the liver. That is MR elastography.
I think we would wind up this interesting session. Thank you, Dr. GN, for your wonderful talk. Thank you very much.